Well, hello, everyone. Really excited to kick this meeting off with this first lecture and two of my favorite people, two of colleagues that I have had the chance to work with over and over again. And before I get to introducing them and getting them involved in what they're going to be talking about, just a couple quick housekeeping things. Remember, when you get a chance to go into the exhibit hall, take a tour around there, talk to some of our industry sponsors, as this meeting couldn't happen without them sponsoring this particular meeting. Remember, there's going to be over $3,000 worth of prizes kind of all over this whole weekend. And so take a chance to go see if you can get one of those prizes. They're going to be a Nintendo Switch. We're going to have a Boys Auto sunglasses, JBL charged speakers. There's a variety of these different prizes out there. And then also, if you are going to get CE, again, we're in the implementation track, so this isn't CE in this particular track, but in the other track, make sure that you go to the CE hub and get your CE evaluation. And then finally, make sure you claim your conference bag, as it has a variety of things in there. It has a glaucoma report. It will take you to different areas as well. You'll want to get your raffle tickets also. And speaking of raffle tickets, I'm going to go ahead right now and give you a bonus raffle ticket code that you can use to go claim a bonus raffle ticket. And that raffle code is Allergan. So without further ado, I'd like to introduce our two speakers for this session. I'm going to start off talking about Dr. Richard Madonna, who a close friend, a colleague, someone that has mentored me, helped me through my career, and it's just an honor to have him here today. He's a professor and chair of the Department of Clinical Education and director of the Office of Continuing Professional Education at SUNY College of Optometry. If you haven't heard him before, he's exceptional at what he does. He lectures nationally, internationally on glaucoma and ophthalmic imaging. He's a past board member and actually past vice president of the Optometric Glaucoma Society, which is a society that is very close to my heart, very close really to Dr. Gould's heart and Dr. Madonna's heart as well. It's a society that we all feel very passionate about and fits perfectly into this particular meeting when we're talking about glaucoma. And then joining him today, Dr. Jennifer Gould is an associate clinical professor and the chief of advanced care services at SUNY College of Optometry. Her clinical interests include ophthalmic imaging, glaucoma, and retinal pathology. She also is a proud member of the Optometric Glaucoma Society and currently serving on that board as well. Welcome to the two of you. Thanks so much for being here and taking your time today, and really looking forward to listening to your lecture today.
Thank you so much, Justin. I really appreciate it. I appreciate all the work you've done, and actually just for inviting us also. And I'll just second what you said, as I've been involved in hundreds of conferences in my career. And again, without industry, they don't happen. So please make sure you support them. So what we'd like to do today is talk about the situation where your patient who you've, let's say, started on prostaglandin medication needs further treatment. In other words, what happens when my patient is progressive? And by that, I mean, we all know glaucoma is a progressive disease, but some patients really have clinical progression and are not meeting the goals that you have for their treatment. So that's what we want to get at today. So let's just jump right in. And there are our disclosures. So we can look at those for a moment. And then with that, I'm going to hand it over to Dr. Gould to get us started.
All right. Hi, everybody. Really nice to chat with you today. This is such an honor to be lecturing with Dr. Madonna, who is also one of my mentors. So before we get going and into the slides today, I think it's important for us just to take a step back and say, well, what is progression? When do we need to make changes in our management of our glaucoma patients? So there's really two scenarios. So Dr. Madonna, mentioned that we have this patient who's taking latanoprost or prostaglandin, a once daily medication, and we're not sure if that's the right thing for them or they might need more. So we really have two scenarios that we need to modify our treatment. And the first is that the patient's target pressure is just, we're not meeting it. So we've staged their glaucoma. We've decided that they're a severe stage. We've figured out a target pressure and we're just not there. So if they're meeting it, we can monitor, obviously, with our many lovely tests that we have, OCT, visual fields, to make sure that we aren't seeing change. But what happens if we actually do see change on those? So we see either structure or functional change, then we need to actually make that change in management. So we're really talking about two scenarios: a target pressure that's not being met, but really the most important part is that we see structural and functional changes and or functional changes over time. So when we are looking at progression, it's really important to take a step back and really think about the progression and think about the patient. Is the patient progressing fast? Is the patient progressing slow? That really matters, because a slow progressor, we might have time on our side. And I know Dr. Madonna and I are both very in the same mindset in this. We have to be convinced to make change in those patients. Where our fast progressors, we really need to pick those up and make changes to make sure that we can not impact their overall quality of life. That's what really glaucoma treatment is about, is making sure that patients have a good quality of life. So in that, some of the time we actually have to take into account life expectancy too. You know, we mentioned earlier those slow progressors. We might not be as worried about making a change today. We might put that off a little bit. But let's say that that patient is a 25-year-old patient who has a strong family history of glaucoma that's had blindness. Now, that patient, we probably need to be a little bit more aggressive with than a patient who is 95, has mild glaucoma, and is slowly progressing. So we really have to take the full patient picture into account when we decide our urgency and how aggressive we are with modifying for progression.
Yeah, Jen, and that's just an opportunity there, and that was really well said. And I think it underscores the fact that every glaucoma patient should have their care individualized. No two glaucoma patients are the same. They may have different outcomes, they may have different rates of progression, and so forth. So please never think of glaucoma as something cookbook. As we talk about medicines later on and treatments, same thing holds. So I'll hand it right back to you.
Perfect, thank you. So I always like to take the opportunity when I see progression or I'm thinking about changing treatment and really go back to the basics of the patient and say, why is this happening? And I think that's important, because if we really understand the why, we might be able to better tailor our treatment. And Dr. Madonna is going to talk a lot about the different types of treatment down the road, where, you know, some reasons that we can have these changes are related to the intraocular pressure specifically. So are we seeing a therapeutic drift? We know beta blockers tend to have a drift over time. And if we decide to modify treatment of someone who we believe has a therapeutic drift, but we just switch them to a combination drop that still has that timolol in it, we have them on probably more medications than they need to be. So we really need to be thinking about the full picture of the patient, you know, again, not making things into a cookbook. Some patients have high diurnal fluctuations in their pressure. High diurnal fluctuations can lead to progressive glaucoma. So that's one of the things that we might need to investigate in our, you know, before we make a decision about how to change the treatment. So this could be even in the case of our patient who we see has structural and functional change, but we always check their eye pressure at 2 p.m. in the afternoon because they always come into the office at the same time. We might be missing some fluctuations of their pressure. And so there's things out there that we can do to try and better evaluate that pressure over time. We also should consider some anatomical variations of the eye. Corneal hysteresis is something that we'll talk about in a little bit, but don't forget narrow angles. Some patients, obviously, if we're following a glaucoma patient for many, many years, we know that the lens thickens over the course of the life of a patient, and therefore they might actually move into more of a mixed mechanism or have a narrow angle or phacomorphic component to their glaucoma. And so by evaluating the anterior chamber, the angle, periodically, it's going to give us a good sense if maybe another SLT or an LPI might be great options for these patients when we do start to notice that things are changing. So again, always want to keep in mind these secondary glaucomas. Dr. Madonna and I were speaking the other day about one of my patients who, she was a weird glaucoma patient. She always was very asymmetric. And we know POAG is asymmetric, but typically somewhat symmetric. And she was mild in one eye and severe in the other. And we could never figure out why she was severe. And all of a sudden, we caught her in a herpetic situation where she had a trabeculitis. The eye pressure was very elevated. And that was a really good time for me to step back and say, oh, look, this is why this asymmetry is there. And that really helped with, the patient by taking that step back and really thinking about what could be going on. It's also important to remember any systemic manifestations of diseases that a patient might have. They might have sleep apnea, hypertension, depending on the medications they're taking, that could be affecting their eye pressure, could be affecting the progression of their glaucoma as well. And so those are things that we definitely want to keep in mind. So the first thing that we'll talk about very quickly is the ocular perfusion of the optic nerve head, because that is really important. So we know that the amount of ocular perfusion is really how much blood supply is getting to the optic nerve. And the reason this is important is because the nerve must have a good blood supply in order to thrive. Well, if we think about ocular perfusion pressure, it's really the difference between the blood pressure, how much blood is getting to the eye, and then how the force of the intraocular pressure back. So it's this gradient together. And we have the perfect scenario to mess with the optic nerve at nighttime. We have our eye pressure. We know that it rises while we sleep. And so we have a nocturnal rise. And if we think about our blood pressure, we know that both our diastolic and our systolic blood pressure dip when we are sleeping or in the nighttime. And so we have a very big difference between the ocular perfusion pressure in this setting. We lower the amount of blood getting to the eye, we raise the pressure, and this really causes an imbalance on the optic nerve head, which can lead to progression. The reason this can be really important is thinking about some of the medications that we're prescribing. Are they working through the night? Can we work with the patient's primary care physician to have them maybe not take their hypertensive medication right before bed so we can keep that blood pressure a little more elevated? So these are some things, bigger picture, that we really need to think about when we're managing our glaucoma patients. So talking about the diurnal pressure, the Eye Care Home is a really great tool, which I know took a little bit of time for us to get implemented, but it's been a really great tool in our bag, especially through the pandemic, for helping monitor some of our glaucoma patients and their pressure when they're unable to get into the office as frequently. So the Eye Care Home is a very similar device to what we all know that we can use for the typical in-office eye care, but this, you can train the patient to use it at home, work with them on having them check pressure through different times of the day. We definitely, if we have patients that are coming in more in the afternoon, we'll recommend that they check it, in the morning, middle of the day, at night. If they wake up in the middle of the night, maybe even have them check it then. And you end up getting a lot of pressure readings on the patient without having to go into their homes and kind of get that pressure reading there. So it works really great. In 2019, there were 3 CPT codes that were approved to help providers be reimbursed for this. And so those include for the different training, because it does take some time to teach the patients how to use it, for renting the device, and then also data interpretation. So this is really important because this study that we have referenced in the bottom there, 69% of patients have their peak IOP outside of the time that we're actually seeing our patients. And so we can't catch that. We might be seeing a patient, they look like they're controlled, their IOP is at target, but when we actually give them this device, we can find that it's not. The example of the patient on the bottom is someone who we actually modified her treatment. And so we had a treatment protocol that we were going with, we modified the treatment, and you can see that the pressure actually went up. So we obviously, that didn't work. This patient ended up going for surgery, but it was a really great way for us to say, hey, let's change something and let's see our results, at home right now, without necessarily having to wait a very long time to see that patient back and really understand what was going on. So I mentioned already looking at the angles. I think OCT and of the anterior segment is vastly underutilized, and I think it's a really good tool in our pockets. We have these lovely OCTs. Let's use them. Doing that gonioscopy, looking for signs of your secondary glaucomas, just to make sure that we really understand, is this truly POAG still, is very, very important. The patient that I have here, this image on the left was taken 2 years ago, and the image on the right was taken a year ago. We can see that there's some thinning, the area of the anterior chamber got smaller over that year, and we can actually see that there's some iridotrabecular contact with this patient. So this was a POAG patient that I'd been following for a very long time. The IOP started to creep up, and so instead of adding another drop on this patient, we actually went the route of an LPI and had very good IOP lowering after. So it's just another thing to think about when we're assessing these patients. So corneal hysteresis is, I believe, the last thing that I'm going to talk about before throwing it over to Dr. Madonna. But corneal hysteresis using the ocular response analyzer is actually very important too, a good concept, newer concept that I think is really great. So I actually have a history, previous career as a mechanical engineer. So Dr. Madonna knows I love talking about these types of things. So what ocular response analyzer or the corneal hysteresis measurement is doing is it's really looking at the biomechanics of the cornea and ocular tissue. And it's telling us a measure of how well the eye can handle stress. So it's a very easy test. It's using an air puff tonometer, and it's going to give you a reading of the corneal hysteresis. What has been found is that there's a good correlation between visual field loss and glaucoma progression in patients who have a low corneal hysteresis. So their eye is not very good at handling the stress of fluctuating IOPs, where patients who have higher hysteresis tend to have less chance of developing glaucoma and less visual field progression. And so this is a really great test. Again, it's a reimbursable test. There's payable CPT codes for this. And so this is something that we can add into our practice to really give you a better sense. Does this patient, is their corneal hysteresis high? Is it low? And that could give us a sense in tying in the degree of progression and deciding how aggressive we need to be with our management. So before we actually talk about how to manage treatment, let's just look at a case because it's always fun to take a look at some patient eyes. So this is a patient of mine. He's a 90-year-old white male with normotensive glaucoma. His current treatment at the time of the exam that we're going to discuss was latanoprost at night in both eyes. He was also taking timolol only in the right eye. And you'll see on the fundus photo on the right-hand side that he has a very large Drance hemorrhage inferiorly. He has a very large cup to disc ratio, very minimal rim tissue. This is obviously a very, very sick optic nerve. His Tmax was 19 in this eye, has a thin corneal pachymetry, and this was not the first Drance hemorrhage that I'd seen. So this was about the third Drance hemorrhage in this eye over a period of about 5 years. His medical history comes into play here. He has a history of chronic inflammatory demyelinating polyneuropathy. He has hyperlipidemia, and he is status post cataract extraction. So using progression software is really important when we're trying to pick up progression. All of the available OCTs right now and visual fields will show you progression using different analyses. We're not going to go into that in this lecture, but this is using Zeiss Forum and looking at the progression of the optic nerve, the RNFL over time. We can see that we have two areas inferior that are showing progression. And on the ganglion cell, we can also see that the ganglion cell layer has progressed over time. One of the things that I always, I'm very strict about with my students and when I'm managing glaucoma patients is anytime I see a Drance hemorrhage, I think it's very important to take a fundus photo because we can actually look, we want to look for structural changes that correspond to that and functional changes that correspond to that Drance hemorrhage over time. And so what's really nice about this photo is we can see this nice Drance hemorrhage here. We can actually compare it to the area that we have that thinning, and we can correlate them together. So this, the top graph over on the left-hand side is his IOP graph. We can see that his right eye has kind of trended just a little bit higher. The date of this Drance hemorrhage, his pressure was 13. It started at 19, so that's actually not terrible lowering for this sort of patient. But the question is, what do we need to do next? And just one more other evaluation that we've really loved to look at is the PANO map on the Cirrus OCT. And so we can actually really nicely visualize the dropout of the ganglion cell and the RNFL over time. and then really nicely see how when you flip the field over, this is his 10-2, perfectly correlates with the ganglion cells. So I think that, we definitely, there's no question this patient is progressing, but I think we have a lot of different options of how to manage him at this point. And we'll kick it over to Dr. Madonna to talk about some different things that we could do.
Thank you so much, Dr. Gould. Just thinking about Durant's hemorrhages, I think a good way to think about them is that they are a sign of past, present, or future progression in many, many cases. And they are really critical to look for. So anyway, my job is to talk about the modification of your treatment plan. And as we said up top, what we want to do is assume that the patient is currently taking a prostaglandin analog only, because in almost all cases, that's where we start treatment. So we're making the assumption that the patient's been started on a prostaglandin, and you can kind of take your choice as to which prostaglandin you wanted to start them on. And now we're then saying, okay, we're not where we want to be. So you determine the patient needs further IOP lowering. Now what? So these are the things that I'd like you to consider when you're choosing any therapy, and in this case, an adjunctive therapy. What's the efficacy? Well, that's kind of obvious. You want something that works. But as we all know, cost plays a major role in the management of glaucoma patients. So that absolutely has to be considered. Generic versus branded folds right into cost, but there's also that thinking that some people have that maybe generics aren't as efficacious as branded medicines. So I separate those two. Adverse effects, of course, are crucial. If the patient is getting ridiculously bad red eyes, they're not going to take the medicine. Contraindications, of course, are important because we don't want to make a situation that's already bad worse. And the last is what I kind of have renamed, what I've taken is tolerability and kind of changed the definition a little bit, which to me is a combination of cost, adverse effects, and convenience. Because if any of those things, cost, adverse effect, or convenience, are not where the patient wants them to be, then they are not going to tolerate that medicine. And therefore, we're going to see a decrease in their adherence to care. So that's kind of the way I look at it when I'm choosing any therapy. And additionally, I probably should have added a slide that says, individualize your care. So this is kind of the bottom half of what you saw before. So again, just to summarize what Jen had said, is that we're looking at a situation where either the IOP isn't at your target, and we're not going to talk about target pressures because that's a whole nother thing to spend time on. But let's just say the IOP isn't as low as you'd like, or you are detecting progression that makes you uncomfortable and you feel as if you need to change your treatment regimen. And the list of things we're going to go over is on the left. I'll just go through them one by one rather than stating them individually now. So one thing that you may want to do, and this is certainly the one that will probably make your patient the happiest, is to maintain 1 drop per day dosing. Again, we've said that they're on a once per day prostaglandin analog, and we've in some way lost control. So can we keep them on 1 drop per day? And the answer is yes. And we have 3 ways we may be able to do that. One is a switching class, meaning switching from one prostaglandin to another. The second is to use a prostaglandin analog with a dual mechanism of action. And the third is to use a prostaglandin fixed combination. So let's look at those. So the first thing I want to show you is a meta-analysis that was published now 6 years ago, but there have been a few others very much like this, and they are very consistent with the data that's been out there since bimatoprost came on the market, which is now almost 20 years ago. And it shows that if you look at really any glaucoma medicine, but certainly the prostaglandins, bimatoprost is the most efficacious in lowering intraocular pressure. So you see, let me put on my laser pointer here. There it is. So you see bimatoprost over here, and then latanoprost, travoprost, and tafloprost right here. Bimatoprost being the most potent. So the situation may exist that if you started the patient on generic latanoprost, let's say, which is far and away the most common treatment, you may have the opportunity to switch that patient over to bimatoprost and get further IOP lowering and maintain the patient on a single drop therapy. So Dr. Gould, I'm going to ask you, what do you think about that?
Yeah, I think that that's actually a really interesting concept for patient management. Over the last probably 1.5 to 2 years, there's been such an improvement in the coverage of bimatoprost or Lumigan. And especially with your Medicare and Medicaid patients, they often end up not having to pay much more or even the same amount as they would pay for the latanoprost. So I think that, as Dr. Madonna said, trying to keep the patients happy and keep them adhering to the treatment is important. So if we can keep them with the once a day and have something that's really about the same cost, I think that that tolerability really does stay there. And so it is important. So I definitely have switched some patients over to Lumigan after trying to get and have seen some good success with that. It's not going to, maybe that point might not be enough for every patient though. So we have to always kind of keep the whole picture and what our goal is in mind.
Yeah, that's well said. And I think it's controversial. I know we have some of our faculty members who just think it's ridiculous to try to do that. And some of you may be familiar with the Myers study that was done 5 or 6 years ago, which showed that at least in some patients, you got a fairly large IOP drop when switching from latanoprost to bimatoprost, which is not surprising to me because, as I said, individualize your care and patients are going to respond differently to different medicines. So it's important to remember that. Another option is to switch the patient to Visalta. Visalta is latanoprostene bunad, and it's a prostaglandin analog with a dual mechanism of action. Essentially, it's latanoprost, the good old latanoprost, but with a bunad modification in which there is a nitric oxide moiety attached to the latanoprost. So in essence, you have latanoprost, which lowers intraocular pressure by increasing uveoscleral outflow, and now the nitric oxide, which increases trabecular outflow. The interesting thing about Visalta is that it was approved by the FDA as a prostaglandin. So it's not a new class. And I'm sure Bausch & Lomb would have wished that it was a new class of medicine. So it's listed as one of your prostaglandins. So there's the package label. It's the lower IOP. We're not going to talk about it. It's once a day dosing, just like latanoprost. The efficacy is slightly greater than latanoprost on average, 1.23 millimeters. It gives you over 30% IOP lowering in high pressure patients. But I think what is really important to remember is that it gives you really good IOP lowering in patients with lower start pressures. And I think that's something that we forget about. We have to remember that when you look at studies on prostaglandins and they say 30% IOP lowering, those are usually for patients whose start pressure is 25. I assure you, if the start pressure is 18, you're not getting 30% on average. So as the start pressure goes down, and that's true for all drugs, and it's true for lasers as well, when the start pressure goes down, you will also get less IOP lowering. Well, Visalta does better than expected at lower start pressures. The adverse reactions are similar to latanoprost, and it's got the same amount of BAK as latanoprost. And cost, not surprisingly, is a new drug. The out-of-pocket is high for uninsured patients, but coverage is improving more and more over time. The other option we have to maintain single drop therapy is a fixed combination with a prostaglandin, and that's Rockfortan. This is latanoprost with natarsadil, which is a Rho kinase inhibitor. This is the first fixed combination with a prostaglandin in the US. There are numerous others in other countries, but the US has none until Rockfortan was approved. It's made up of latanoprost, which increases uveoscleral outflow, and natarsadil, which increases trabecular outflow, but also, and importantly, reduces episcleral venous pressure. And if you remember, the episcleral veins are kind of the back end of the trabecular outflow system. With drop therapy or any therapy that affects the trabecular meshwork, you can't get the IOP lower than the episcleral venous pressure. So if you lower the episcleral venous pressure, you have the ability then to lower the intraocular pressure even more than you may have with drop therapy. And just very quickly, this is an efficacy slide for Rockfortan. It's comparing Rockfortan to the individual components, Ropressa and latanoprost. And if we just look on the far left, we can see that about 3 times as many patients had pressures less than 14 on Rockfortan treatment as opposed to Ropressa or latanoprost. Okay, so those are our 3 mechanisms to try and maintain patients on single drop therapy. Jen, you want to add anything there, or?
No, I think you're good so far.
Okay, so I'll keep going, and please jump in as you see fit. Now, some people may be more comfortable at this point to add another medicine. So we call that adjunctive therapy. And you really have 2 opportunities here. You can add a single agent or a fixed combination, 2 medicines in one bottle. So if we think about the single agents, we have 4 classes of medicines: beta blockers, alpha agonists, carbonic anhydrase inhibitors, which we all know well because they've all been around for a very long time. And then a new player, the Rho kinase inhibitor, which is natarsadil, which we just talked about. And by the way, some of you are saying, wait a second, Madonna didn't talk about the side effects of Rockfortan. We're going to get to the side effects of Rockfortan as part of side effects of natarsadil alone. So I apologize, I should have said that. And the considerations when we think of adjunctive therapy are the considerations I talked about before: efficacy, side effects, contraindications, dosing, cost, generic availability, all going into tolerability. But also think about mechanism of action, because it's important to remember whether we're talking about aqueous suppression, uveoscleral outflow, or trabecular outflow, and nighttime efficacy. And I'm going to ask Dr. Gould her thought about that, because she was talking about perfusion before when we have the opportunity. So quick review on the beta blockers, again, out since 1978. The efficacy, in my mind, is similar to the others when added to a PGA. Some people may disagree with that, but I think they're all pretty similar. And it's just an inter-individual variation that we see where some people do better than others. We know the side effects. It's a well-tolerated drug locally, but please don't put patients with COPD or asthma, 2nd and 3rd degree heart block on this medicine. I love the fact that beta blockers can be dosed QD in the AM. Don't use them at bedtime, which we'll talk about in a moment. They're cheap because they're generic. The mechanism of action is reduction of aqueous production, but their nighttime efficacy is poor. We will return to that. Alpha agonists, again, I feel are similar in IOP reduction when added to PGA, similar to beta blockers and CAIs. The big side effect is allergy. If you were around when the original Alphagan hit the market, there was a huge number of allergies to that medicine, but that has been reduced considerably by reducing the concentration of the active agent and using purite as the preservative as compared to BAK. There's some relative contraindications. The dosing is usually BID as an adjunct, although it is labeled as TID. The cost is all over the place. It can be high based on coverage, certainly for the branded agent, which is Alphagan P. Again, there's generic availability, but remember about the generic. Generic brimonidine is 0.2% in BAK as opposed to 0.1% with purite. So they are kind of different agents. It is a aqueous suppressant, but it also increases uveoscleral outflow. And again, nighttime efficacy is poor. The CAIs are well known for their local side effects, redness and burning, and also change in taste, which I guess is more of a systemic side effect, but it's kind of local. It has relative contraindications in things like sulfa allergies and kidney stones, but I think most studies have shown that there is really very little crossover with the topical medications and oral CAIs. It's usually BID, cost is high, but again, based on coverage, there is generic availability as seen by the dorzolamide that you see on the right. It's an aqueous suppressant, and sort of in bold, nighttime efficacy gets a big yes. And let's look at that one. This is one of a series of of papers written by John New and Bob Weidenreb's lab out in UCSD. And what you see is latanoprost. This is daytime. Here's nighttime. Here's latanoprost alone, and it lowers IOP well, and it works during the nighttime period. When we add the CAI to it, you can see that we also get good IOP lowering here. But when we add timolol to the latanoprost, we see no real difference between latanoprost alone. So this tells us that the CAI provides nighttime coverage and lowers IOP during the nighttime period as opposed to timolol. And the same would be true of brimonidine. So Dr. Gould, if you could put that into perspective for us, based upon what you told us before about perfusion pressure.
I think it's a really, really important concept to think about because, you know, if we tried to dose a patient with a medication that's going to not maybe lower their IOP as much at nighttime, and we have that dip in the blood pressure, we have a bigger span between the ocular perfusion pressure. So from a theoretical standpoint, and obviously my engineer head likes a theoretical standpoint, it makes sense to do something that's going to minimize the change between the blood pressure and the IOP. So this is one of the reasons when I dose a beta blocker or timolol, I typically don't dose it at nighttime. First of all, it's not going to do much work, but also I don't want to potentially have any impact on the blood pressure and kind of the whole scheme of the patient that could impact that ocular perfusion.
I agree with that totally. So I think the take home on this is if you think your patient is being affected by poor perfusion during the nighttime period, they may be a dipper and have very low blood pressure. I would urge you to consider using a CAI as your adjunctive agent. And then we have Ropressa, the Rho kinase inhibitor. And again, I think the IOP lowering is similar. But again, episcleral venous pressure and the lowering of episcleral venous pressure may allow it to drop pressures more. And I think I think many people have found that there are some patients who really, really respond well to this medication. The big deal, and this would hold true for Rockfortan as well, are the side effects. There are some patients who get very bad hyperemia or conjunctival hemorrhages from this medicine, and they need to be forewarned at the beginning of treatment. Otherwise, you may have a patient who quickly wants to come off the medicine. What we find is that some of these patients will have hyperemia, come at their next visit, look much better, get worse again, and so forth. But I think with this very effective medicine, I think it's important to tell your patients that they may get red eyes that may be periodic so that they're not surprised. The great thing, one of the great things about the Rho kinase inhibitor is that there are essentially no systemic contraindications to this medicine. No, not essentially. There are no systemic contraindications to this medicine. It's dosed QD in the evening. So if you wanted to use this, let's say you didn't want to put them on Rockfortan for whatever reason, you could use this in the evening with the prostaglandin analog. So the patients are often very happy because they can use both their drops at the same time of day. Like no other new medicines, the cost is generally high, but depends on coverage. There's no generic availability. And we've already talked about the mechanism of action. Ropressa has been shown to have good nighttime efficacy, like the CAIs, like prostaglandins, but unlike the beta blockers and alpha agonists. So the next opportunity you may have is adjunctive therapy with fixed combinations. And I think this is well known that the advantages are to reduce the number of installations, reduce washout. You get excellent IOP lowering. These are excellent medications. And more rapid IOP lowering, which I think is important because if you go one medicine at a time, it's going to take you a while to tell whether the medicine was efficacious. And I think, you know, in having treated glaucoma now for over 30 years, I think sometimes getting to where you need to get quicker is the way to go. And I think, you know, that's important. And if we look at what prescribing patterns, we see that fixed combinations are really being prescribed much more than they ever were. The disadvantages are you're adding two meds at the same time. So you don't know if you could have gotten where you would have gotten by only putting the patient on one. You don't know the efficacy of each one. We also think about the side effect profile, but I think that's theoretical because if you take like Simbrinza, it's brinzolamide and brimonidine. If the patient says this, they got a funny taste in their mouth, it's coming from the brimonidine. If their eyes look like they're raccoon eyes from allergy, it's the brimonidine. So I think that's kind of more a theoretical disadvantage. And cost is a disadvantage because these tend to be expensive, although one is generic. And I think these are well-known medicines. So we have COSOP, preservative-free COSOP, which I think is important. We're not really getting into dry eye today, but I think as we think about adding medicines to patients, think about the number of medicines, the amount of BAK that's being plopped into the eye. Combigan and Simbrinza listed for you, very effective medicines. And we mentioned Rockfortan. Now, this is kind of the newest area. SLT is not new, but the way we're thinking about SLT and cataract surgery and MIGS procedures with cataract surgery or cataract surgery with MIGS procedures, I do think those are two different things. And implantable devices. We're not going to talk about surgery today. That's not really the type of case we're talking about. But we're really talking about what's sometimes being called interventional glaucoma treatment or glaucoma management, which means being proactive and really intervening with a procedure which changes the arc of the disease. And I think that's what we're talking about here. So I'll very briefly go through those because I think questions may come out of this. We all know about SLT. The number of SLTs that are being done are increasing rapidly because of the LIGHT study, which actually only looked at starting people on SLT. But now we're seeing many more SLTs being done adjunctive. And SLT is really an excellent treatment. Equal efficacy to a medicine, reduces the medication burden, which I think is crucial. Over time, it's lower cost as opposed to medicine, and it provides nighttime IOP lowering. Jen, I'd like you to comment about what you're seeing at SUNY, for instance, in terms of the number of SLTs that we're doing.
Oh, it is. We bought an SLT about 3 years ago, and we are doing pretty much first-line therapy for most of our glaucoma patients at this point. And then I have found that most providers, instead of adding a second drop or something, or we're going to the SLT next, we're doing a fair amount. It really has increased over the last couple of years and really good success. I mean, over 7 years of me doing this with the surgeon that I work with, we've had very few complications, maybe a lingering uveitis from time to time, but a really safe and easy procedure. And it's easy to explain to the patients too what's going on, and they're happy to reduce the burden and kind of increase the quality of life for a period of time.
Yeah, I think that's what we're really seeing. It's interesting because this morning, on Friday mornings, I have a glaucoma elective with one of our other colleagues, Matt Babenzi, and we did some polling of our students, and it was amazing how often they picked SLT as primary treatment, as secondary treatment, as patients I wouldn't have done an SLT on. So we've almost seen the whole thing flip on its head. That's the number of SLTs that are being done. And then we have the whole, and it's great having Justin on here, because to me, Justin is kind of optometry's leader in understanding MIGS procedures and seeing MIGS procedures as part of his practice. But to me, the goals of MIGS procedures, we're certainly not going to go through all of those that are available, are of course to reduce IOP, but I think sometimes people forget just as important is reducing the medication burden to the patient. So to me, if you have a patient who has a pressure of 13 on 3 medicines, and you do a MIGS procedure, whether you do it with cataract surgery or not, and at the end of the day, they have a pressure of 13, but they're on 1 medicine, that is a huge win. And I think it's really important to keep that in mind as you navigate, should I be using a MIGS or not? And I think, what I think we're going to see in the next few years is more and more use of MIGS procedures as standalone procedures and not just with cataract surgery. As you know, a number of them can only be done, or at least are only FDA approved to be done in conjunction with cataract surgery. Maybe Justin can comment on that when we wrap up here, because we're just about done with our prepared portion. And that's kind of what I just said. The first bullet I didn't say, should all glaucoma patients who are undergoing cataract surgery also get a MIGS? Actually, I would like to stop for a second and ask Dr. Gould her opinion on that. And maybe Justin, your opinion too. I mean, you're allowed to play also.
Yeah, so I work really closely with one of our cataract surgeons as well. And I will tell you that probably 90% of patients that come in that have glaucoma are leaving with, a referral for a cataract with MIGS. It just makes sense to try and reduce the burden on the patients.
Justin, is that what you guys do? Again, you've probably done more, been part of the care of more MIGS procedures than any optometrist, or maybe Mitch has. I'm not sure which of you guys, but your thoughts?
No, great question. Yeah, I mean, I've done, 2012, we implemented MIGS procedures in our practice. I've, seen it's a staple in our practice. And what you said is spot on. I don't have a lot to add. I mean, yes, it's important to lower pressure, but the fact that you can reduce medication burden is such an important piece, because quality of life plays just as important of a role in these patients' lives with medication burden as the disease of glaucoma taking their sight does. And so you hit it right. You were spot on with saying that medication burden piece is probably just as important as lowering pressure with these things.
Yeah, and I think that's what's forgotten a lot of times. And I think we all, and over my career, I'm sure many times I've forgotten about the medication burden. And now, just because we have this opportunity now with interventional management to really reduce that burden to our patients. So thank you both for that. And I just want to mention Duristan. And I'm not sure everybody is familiar with this. This is a bimatoprost implant that was approved like the first week of the pandemic. So I think this was just lost in the shuffle for a while. But you can see the size of it on the finger, and you can see what it looks like in the anterior chamber. This is an intracameral device. It is injected into the anterior chamber. Allergan, I know, would like to see this approved for multiple implants given every 4 months or 6 months or whatever the case may be. The FDA only approved it for a single implant per eye, because they really want to watch for drops in corneal endothelial cell count. You may remember what happened with the CyPass device in the uveoscleral outflow system. The contraindications are the same as with prostaglandins, and you shouldn't use it in narrow angles. But this might be a device that will be useful for patients, let's say, who are poor adherers, or they just don't want to take drops. Now, they would have to get a needle into their eye, and some patients aren't going to like that. But I do think there's going to be a place for Duristan. And one other interesting fact about it is that after, let's just say 6 months, there's no real active agent left in the eye. But yet we're seeing IOP lowering out in some patients out to a couple of years, telling you how the prostaglandin analog actually remodels the uveoscleral outflow system. And in some patients give you very long-lasting IOP lowering. So Jen?
Yeah, I think just kind of wrapping up quickly, now if we look back at this normotensive patient and think about that we obviously have progression, we have him on a PGA, we have him on timolol once a day in this eye that's showing progression, there's so many different options of things that we can do. And at the end of the day, all of them would be right. We really want to just make sure that we're improving the patient's quality of life, making sure that we are monitoring and watching for further progression through life. But I mean, in some cases, we could take him off the timolol, put him on, Ropressa might be a great option for him. Same dosing, and we might get even more lowering while paying attention to that ocular perfusion pressure. We could do a MIGS procedure, even though he's already had cataract surgery. So there's lots of options and lots of things that we can do for our patients. But really the most important thing is just continuing to monitor and keeping in mind the patient in their personal life and how they're affected by their glaucoma.
Yeah, and my last take on this is what we have found with optometrists is optometrists are very comfortable in starting prostaglandins. But then when we reach this step of adjunctive therapy or another therapy, we're seeing a lot of people drop out. That's the way glaucoma is. Be comfortable in the fact that you have many, many treatment options and just understand what all of them do and realize that most glaucoma changes slowly, allowing you enough time to make decisions or to see how decisions work. So be comfortable with that. Thank you all. Justin?
Just exceptional. Thanks you guys for that lecture. We have time for one question that I want to bring up, but I loved the slide where you kind of broke down the kind of flow chart of options and what do you do after a patient has been on prostaglandin. That chart, that slide was just money. So thanks for sharing that and going through those different options. So
it's in your journal, so that you're the editor of.
I do know about it. Yes. I'll tell you, there's a poll question, which I'm going to put you two on the spot, but it's an easy question for you two, as much managing of glaucoma you have. But there's a poll question we asked, and we asked the question, when my patient isn't adequately controlled on a prostaglandin and showing progression, what's my next step? And so I'll give you the results. About 35% said they would switch to another prostaglandin within the class. 30% or so said that they would add a single agent. 15% said they'd go to surgery. 10% said they'd switch to Rockfortan, and 10% said do a switch to a combination agent. So Dr. Gould, what is your go-to, or what are you doing? You don't have to be brand specific, but what do you do next if someone's not adequately controlled typically?
Yeah. I think most of the time I'm moving to SLT at this point. I do think it just increases quality of life. I think it creates not having to add any more burden onto the patient, and most people tolerate it very well. So that's really my go-to at this point, is an SLT second.
Dr. Madonna, to wrap us up.
When you said surgery, that included, I assume, laser.
I believe, yes. In a group there, yes. And I should have mentioned that, correct.
I'm going to give the same answer that I gave in my elective class this morning, because we were talking about the same things. It depends. It depends on all of the factors that were mentioned in this talk and probably others. But I think, if I was just looking at a generic patient in the generic case, I think more and more we're seeing that trend, and I think it's a good trend, toward getting SLT on board earlier. And, just looking ahead, I think there may be even opportunities to get patients off of prostaglandin and re-baseline them and just try an SLT then. But that's a little out there. Nobody's doing that right now. But I think if you look at the science, it kind of makes some sense to maybe do that. And that would be true interventional glaucoma management.
Well, again, I can't thank you two enough for taking the time today on a Friday to spend it with me and to spend it with everyone that attended. It was excellent. I appreciate it, and look forward to seeing you both very, very soon.
Yeah, thanks, Justin, and thank you for putting everything together and for including us.
Yes, thank you so much.